Okay, we are officially live. Hi, everyone. I'm Taylor Blair, your community manager and digital marketing specialist here at Vitality Connect. We're going to get started in just a couple of minutes. As more providers log on, we are so honored to have the Judson Brandeis, Dr. Judson Brandeis here today to talk through focused versus radial waves, a very high demand topic. But while we wait for more providers to log on, I wanted to announce another upcoming webinar we have on October 7th. This webinar will discuss the development of therapy for erectile dysfunction, the latest treatments that providers can adopt to improve their patients' erectile function and levels of sexual intimacy. I'll put the registration link for that webinar in the comment section of this webinar. Also, I wanted to remind you about some exciting features that come with being a GAINSWave provider, in addition to your amazing portal, tools, content, support from our team of experts. So we have a complimentary PR opportunity available to all of our providers. And this is through the Amazing Health Hacks podcast. Get interviewed by GAINSWave CEO Mark White and gain exposure through this trending channel. If you want to apply as a guest, just email Adrian@vitalityconnect.com. That's ADRIAN @vitalityconnect.com. We also continue to use the medical discussions questionnaire that used to take place in our former forum. Now we've moved that to the medical questions topic of this Facebook page. So add to these questions or responses, post new ones on the page, and they'll continue to be filed under the topic, which is now a hashtag in the Facebook functionality. If you ever have questions on how to navigate the Facebook group or want to do a Zoom session with me, just email me, taylor@vitalityconnect.com. We want this to be an open discussion, talk to us and talk to each other. Lastly, we want to let you know that we love for your staff to join us on this Facebook page. So this page is closed to providers only, but we welcome any medical or office staff who you are working with so that they too can access these amazing member benefits. Okay, we're going to get started and I will hand it over to Dr. Brandeis. Just some quick housekeeping. During the live session, please ask questions as they come up and we will get to them at the end of Dr. Brandeis's presentation. If you have any follow-up questions after the live session concludes, feel free to post the questions in the group or in the comment section, and I will make sure that Dr. Brandeis sees them. If that sounds good, please like and comment below. Okay, let's get started. Hi, Dr. Brandeis.
Awesome. Hi, Taylor. How are you?
Fantastic. Really excited for today's topic.
Oh yeah, this is like the thriller in Manila, right? For shockwave therapy, right? This is focused versus radial, and there's just this raging debate between those two technologies, you know, which one is better? Are they the similar, et cetera, et cetera. So without further ado, let's get going. First, I have to figure out how to advance my slides. There we go. Okay, focused versus acoustic waves. Okay, a focused wave has a really rapid rise, 10 nanoseconds, whereas a radial acoustic wave has a rapid rise, 10 microseconds, but it's a lot, what is that? Micro to nano is 1,000 times less than a focused shock wave. Now, whether a microsecond versus a nanosecond matters, I don't know. But technically, there's a difference between the rise of a focused wave and a radial acoustic wave, okay? The source of focused waves, they're either piezoelectric from a crystal, electromagnetic, or electrohydraulic. And then for a focused, for an acoustic wave, it's either, they're all ballistic, meaning a bullet basically bounces back and forth against a strike plate, and it's either electromagnetic or pneumatic. Okay, and then a focused wave is a class 2 device, which at this time for erectile dysfunction, supposedly it limits the use to physicians in IRB approved trials, whereas a class 1 device can be used by anyone. And then the critical difference really is where the energy is at. So for a focused wave, the wave comes together at a point, whereas a radial wave, the energy comes from a point and goes out. And because of that difference, the depth of penetration of a radial acoustic wave is 3.5 centimeters, a little bit less than 2 inches. And the depth of penetration of a focused shock wave is 11 centimeters. Now, I'm out in California. Maybe in Florida, you have guys with penises that are 11 centimeters in diameter. But in Florida, most guys' penises are not 11 centimeters in diameter. They're 3.5 centimeters or less in diameter. So that is an important difference. And also it's important, and all joking aside, when you're using a focused shock wave, the kidney with kidney stones is about 11 centimeters deep. And so that's why focused shock waves work really well for kidney stones, but radial acoustic waves would not work for kidney stones because the depth of penetration is, way too shallow. But for a penis, obviously there's a big difference. Okay, just a brief commercial break. I want to thank everyone out there for supporting Affirm Science, for purchasing wholesale for in-office sales to your patients. Because we get sales from Affirm, I have the time to put together slideshows like this, focused versus shockwave versus radial. I did one on PRP. I did one on GAINSWave. You can go back and look at all of the educational journal clubs that I've done. And because the GAINSWave community supports Affirm Science, it frees up a little time where I can try to keep everyone up to date on all of the developments in this really exciting field of regenerative sexual medicine. Okay, so the devices. On the radial side, you have the Zimmer device, which costs between $30,000 to $40,000, and it's a class 1. You have the eVive device, which is about $30,000. You have the Refine USA, which is about $40,000. And you have the Stores Deactor, which is about $25,000. The focus devices, because the technology is a little bit more complex, tend to be more expensive. So the Eurogold is about $60,000. The Stores Duolith is around $60,000, and the Alma Duo is $180,000. To me, that's a stunning amount of money for a focused shockwave device. For $180,000, it would not only have to improve erectile function, but maybe vacuum the floors, clean the sinks, answer the phones, and do the accounting. That $180,000, I don't know why it's so far out of range from the rest of the machines, but that's the cost that we were quoted. Okay, so there are only 2 papers comparing focused and radial waves, but I want you to take a look at this homemade diagram first. So on the left, we have a radial wave, right? So the highest energy intensity is at the tip, and the energy radiates outward. And then the 2 red lines are basically meant to be the penis, right? And so you have a fair amount of energy that's going through the penis, and what it's doing really is shaking the cell membranes of the endothelium and the vascular cells, stimulating stem cells, causing the release of vascular growth factors, and creating neoangiogenesis, the growth of new blood vessels. Okay. And then on the right, you have a focused shock wave. Now, the question really is, where is the focus of the focused shock wave device? Okay. But think about it this way: when we do shockwave therapy for kidney stones, we're focusing the energy on a kidney stone, and usually the focal field is about a centimeter and a half, but that's because we're 12 centimeters deep. The penis, if you focused all of that energy of a focused shock wave in the corpora, I think that you would cause tissue damage because that would be the total intensity of the shock wave. So the focal point of the shock wave of a focused device is going to be somewhere outside of the corpora. And so I'm having trouble really understanding what the true benefit of a focused wave is if the focal point is not in the tissue that you're treating. So to me, in my sort of simple understanding, and maybe some of you guys are physicists out there and know this stuff better than I do, but the wave, the main difference between the wave is just the rise, but it's microseconds versus nanoseconds. And then really the intensities are fairly similar. The focal point of the focus wave is outside of the penis. So you're just getting these spiked waves coming through the tissue. And so I'm not really sure biologically why there would be a difference between a radial and a focus wave. But I would, if there's someone out there that's smarter than me about this kind of stuff, I would welcome any thoughts. Okay, so let's get down to the two papers. The first was written by a good friend of mine, Danny Shaskas. He is a professor at the Cleveland Clinic, and he did a retrospective comparison of focused shockwave therapy and radial wave therapy for men with erectile dysfunction. Okay, and this, I think, was a 2020 paper. Okay, so it's a retrospective study. There are two different sites. One's actually in the Cleveland Clinic and one is a satellite clinic. The protocol was 6 weekly treatments. The radial device was the Zimmer on-pulse radial device, 10,000 shocks, 90 millijoules at 15 hertz. I have a Zimmer. I find that it works pretty well. And I use a very similar protocol that Danny does. 10,000 shocks, 90 to 100 millijoules, 15 hertz. The true shockwave device was a Eurogold, 3,000 shocks at 0.9 millijoules per millimeter. And what they did is they checked the pre and the post shim scores. And important to note, no adverse events encountered with either technology. No paper that I've seen reported in the literature any significant side effects from any of these technologies. Okay, so these are the baseline characteristics of the two treatment populations. Very similar age, very similar duration of erectile dysfunction, very similar rate of use of PDE5 inhibitors, a similar number of treatments, and a similar pre-treatment shim score. Okay, so let's see what happened. Okay, so the focused shockwave therapy started at 9.3 and went to 15.5. So pretty good, that boosted the shim score about 6 points, which is great. It's a big improvement. It moves you up one class of erectile function. Okay, let's take a look at the radial. Started at 9.3, post-treatment went to 16.1. Wow, that's pretty good too. So that's an improvement of about 7 points on the shim score. So that also is a really good outcome. So let's compare now the focused shockwave, which improved 6 points on the shim, and the radial shockwave, which improved 7 points on the shim. But a p-value of 0.4 means that there's really no significant difference between a 6 and a 7. So in this comparison, I would say that it's no difference between focused and radial shockwave. Okay, so that's just one paper. Let's go to, there's only two papers, remember? Let's go to the second paper. This one is out of Turkey, the Department of Urology of the Van Educational Research Hospital in Van, Turkey. And this was done in 2019, and looks like it was published either 2019 or 2020. So these are all very recent papers. Okay, so the methods for this, they used an old protocol of twice a week for 3 weeks, then a 3-week break, and then twice a week for 3 weeks, again, for a total of 12 treatments. So Cleveland Clinic used 6 treatments. They used 12 treatments. They used a device called the Elettronica Pagani. It's an Italian device that I'm not familiar with, but I guess there's 2 different modes. There's a focus mode and a radial mode for this particular device. And they used 1,800 shocks at 0.15 millijoules per cc. And they checked the IIEF, which is bit 5, which is basically the shim score, and then the EHS, which is the erectile hardness score at baseline and then 3 months after treatment. Okay, and so the age of this group was basically the same. The body mass index was similar. The testosterone levels were similar. It's interesting to see 85% of these 45-year-olds were smoking, and that's why they were getting erectile dysfunction at such an early age. 45% had high cholesterol, so they're eating too much pasta, I guess, in Italy. Oh no, Turkey. What do they eat in Turkey? Hummus? Hummus is good for you. I don't know, these guys are smoking, they're eating bad food, they have hypertension, over half of them have diabetes. And so this is even though it's a young group, it's a relatively unwell group. All of them are treating themselves with PDE5 inhibitors, and their baseline IIEF5 score, 9.6 and 10. So very similar. Okay, so let's take a look at the focused group. The IIEF5 went from 10 to 15. So that's pretty good result. And the erectile hardness score went from 2.1 to 3.4, which also is a pretty good result. So this young but unhealthy cohort of Turkish men got a good result from the focused treatment. Now let's take a look at the unfocused treatment. The IIEF went from 9.6 to 15.9. Wow, so even better than the focused. And the EHS went from 2 to 3.72. So there again, a little bit of an edge to the unfocused versus the focused. But when you take a look at the p-values, when you're looking at an increase of 5.5 versus 6.5, you're not going to get much of a p-value. So basically, statistically, these are similar values. When you look at the percentage of patients that had a treatment success, the focused benefited 50% of men, and the unfocused benefited 65% of men. Okay, so let's sum up. Cleveland Clinic study, no difference between focused and unfocused or radial. The Turkish study, no difference between focused and radial. And when I was getting ready for this talk, I called up Danny Shaskas, who's a friend of mine, and I asked him point blank. I said, Danny, I saw your paper. I saw the Turkish paper. I said, but, there's all these claims being made that focus works better, et cetera, et cetera. What do you believe in your heart of hearts? And he said, I don't think that there's really any difference in terms of the efficacy for this particular indication of focused versus radial. And Danny's a really, really smart guy. He runs the board review course, and he's a professor at Cleveland Clinic. And so if, I believe the kind of stuff that he says. Okay, so, but what about other studies? Like, are the studies that I just quoted to you, are they way out of line with everything else that's been put in the literature? And so there was a meta-analysis from Clavijo that showed a shim score increase of 6.4 versus a shim increase of 1.6 for sham. So, the numbers that we're getting here, between 5 and 6, they're consistent with those meta-analyses. And then if you take a look at the other 5 meta-analyses from Liu, Dong, Campbell, Rurdink, and Bacalini, they all show an increase of shim score of these technologies, mostly focused between 2 and 4.2. So, I wanted to see, like, okay, these 2 studies that compared focused and radial, were they aberrations, or were they pretty much in line with other things that we've seen? And basically what it shows is they're pretty much in line with everything else that we've seen. So that there's no reason not to discount. There's no reason to discount the data in those studies. Okay, so what about other fields using shockwave therapy? So orthopedics is a field that uses shockwave therapy, both radial and focused, and they use it for things like biceps tendinopathy, knee tendinopathy, plantar fasciitis. And there was a meta-analysis of focused shockwave and radial shockwave in soft tissue musculoskeletal injuries. And what it showed were that, one, they were both equally safe, which is great to know. And then there were varying efficacies, but there were no head-to-head comparisons, right? So in a field like orthopedics, where this is used in a widespread manner for a number of different medical conditions, they really haven't shown a difference between focused and radial shockwave. Okay. Okay, so let's talk about the cost. Is it worth it? So the Zimmer device, there's the OnPulse Pro is $30,000. The water-cooled device is $40,000. The eVive is $30,000. The Refine is $40,000. The Storz D-Actor is $25,000. Okay, so if you get a radial device, it's between $25,000 and $40,000. And your results, at least according to these two studies, which are the only two studies that have ever looked at this, are exactly the same as the Eurogold and the Storz Duolith at $60,000, and the Alma Duo at $180,000, which not only does shockwave, but also answers the phones, cleans the kitchen, mops the floor, and I think that's it. You have to get the next level device to do other functionalities for more than $180,000. And these are FDA Class 2 devices. So if anyone ever came after you and said, well, the doctor didn't do my treatment, this is an FDA Class 2 device, I think it would be difficult for you to defend yourself, although I don't know the legality of that. Okay, so just to beat a dead horse, the two comparative studies show no evidence that focused shockwave is superior to radioacoustic wave therapy in the treatment of erectile dysfunction. In fact, they are statistically no different, and non-statistically, the radial shockwave actually outperformed the focused shockwave by a little bit in both studies. The outcomes of these two studies are consistent with the existing literature. So it's not like these two papers are an aberration. The numbers and the results that we're getting in these two studies are pretty normalized. In orthopedics, there's no direct comparison of focused versus radial, but both technologies are safe and effective, and neither one has been found to be superior to the other. And focused shockwaves are more expensive than the radial wave machines, especially the Alma Duo, which is 2 to 3 times the cost of even the focused shockwave machines. Okay, so that ends the debate on focused versus radial shockwave. Clearly, there's a lot more work that needs to be done. We all should try to do studies or seek out to be involved in studies because we all, as doctors who treat these patients and physicians who are well trained, can make a contribution to the world literature. Okay, now I want to talk about my most recent project, which is really super exciting to me. It's my book called The 21st Century Man. This was my COVID project, and it started small and ended up snowballing into a massive effort involving actually 60 of my friends and colleagues, and 900 pages and 101 chapters. And it really, the genesis of it was that I saw so many men who came to my office when they basically ran out of gas, right? They were in their late 40s or 50s or 60s or 70s. And erectile dysfunction is sort of one of those things that happens when you get depleted, when your cardiovascular system's not working as well as it should, when your hormonal system's not working as well as you should, when your relationships aren't working. And I really wanted to write a book for men between the ages of 35 and 85 that would help them with early intervention, prevention, and finding a good doctor when they needed one. And so the beginning of the book, called The Journey, is about inspiring men, because at the end of the day, we all kind of know what we need to do, right? We need to eat better, eat less, exercise more, stretch, do yoga, don't drink, don't smoke, don't do drugs, do some meditation. But at the end of the day, most of us don't do that, or don't do it really to the extent that we need to do. And so the first part of the book was really to inspire men to live better lives. And then preventative maintenance, we took the top 10 causes of death in men: heart disease, cancer, accidents, strokes, diabetes, et cetera, and we got experts in each of those fields to write about early intervention and prevention of those kind of things. And then we talked about specialty care. So vision, hearing, sleep, hand health, foot health, all those kind of things. And then we got experts in nutrition to talk about food, experts in exercise to talk about how to get into shape, and then experts on addictions, because so many men get sidetracked by smoking, by alcohol, by marijuana, by cocaine. And then there's a section on looking good. So hair removal, hair replacement. I have cosmetic surgeons, plastic surgeons, cosmetic dermatologists writing those, dentists writing those chapters. And then we have a lifestyle chapter on male design, on the bond of sports, on literature, and then a whole section on mental health. So many guys get derailed by anxiety, depression, those kind of issues. And then relationships. We have chapters written by therapists, by psychologists, by psychiatrists. And then I'll go into, in just a minute, the sexual healing chapters and the sexual medicine chapters, which are really exciting. Then I have a whole section on health insurance written by health insurance executives and public health students. And then in the end, we talk about how to leave a legacy. So I have a chapter on inspiration, chapter on gratitude, a chapter on leaving a legacy, and then the final chapter on continuing your life's journey. So I just want to talk a little bit about what's in the sexual healing and sexual medicine chapter, because I think, there are a number of books that have been written on this subject, but just embedded within this massive text, I have a chapter on sex on the beach, which is, what happens when things go right. Erectile dysfunction explained, which is what happens when things go wrong. Then I have a section on orgasms, too fast, too slow, or just right. You can use your imagination for that. And then a comprehensive approach to sexual function. So this is how, when I see a patient in my office, I approach that patient and the treatment of that patient. And then Wave Goodbye to Erectile Dysfunction talks about GAINSWave. Viagra and Beyond talks about Viagra, oxytocin, PT141, apomorphine, all the extra things that we can do for treating erectile dysfunction. I have a chapter written by Joel Kaplan on penis pumps, a PRP chapter, amazing PRP chapter written by Charles Runnels, an incredible chapter on stem cells written by Jeff Picarillo. And then Ed Cartman wrote a great chapter on penile implants. And then a really fun chapter written by Dirk Bauer and myself. Dirk Bauer is the CEO and founder of the Fun Factory on sex toys. And then Milian Poa comes from Global Protection, which is a huge condom company. And we wrote about everything you need to know about condoms and lubes. And then Susan Bratton just wrote a spectacular chapter on how to please a woman. And then Gary Donovitz, the CEO of BioT, wrote a fantastic chapter reviewing testosterone in men. And then myself and David Miller, who's a great urologist in Virginia, wrote a chapter on prostate health. Then I wrote one on Peyronie's, circumcision, sexually transmitted infections, vasectomies, and then a good friend of mine who's a national expert in fertility male fertility. Phil Worthman wrote an amazing chapter on male infertility. So I hope, one, that you'll be interested in picking up this book, but also recommending it to your colleagues and to your patients, because really, I don't think there's ever been a book like this that is so focused on men between the ages of 35 and 80 and the medical problems that men have, written in a way that men appreciate, right? So even though it's 900 pages, it could be 9,000 pages. I hate reading a book that's 300 pages and saying to myself, that this whole book could have been pushed down into 10 pages and I wouldn't have wasted the last 10 hours of my life reading something where I just picked up a couple little things. Each chapter is so packed with information, written in the active tense, written in a way that guys can get a lot out of reading one chapter in a very short period of time. And even though it's a long book, each person's book is only going to be 300-400 pages, right? So if you don't have any addictions, don't read the addiction section. If you look like Fabio, you don't have to read any of the looking good section. If you're expert in exercise, you don't have to read the exercise chapters. But every man is going to have chapters that are his weaknesses or areas where he could improve in. And that would be super relevant for him to read. So I thank you for your attention. It looks like in the great battle between focused and radial shockwave, we have a draw. So I'm happy to take any questions that anyone might have.
We do have quite a few questions, but first I want to say congratulations on your book. That is a star-studded book. Really, really excited to see that. And do you have a link that we can post on how our providers and other community members can get the book?
Yeah, not quite yet. So the advanced review copy comes out on the 10th of October. We're going to have a big party at my office. And then the book will be available for sale about 2 months. So maybe, hopefully early November. Although we should have an ebook and an audiobook probably out before then.
Cool.
But I'll keep you informed.
Okay, yeah, please do. And whenever we do get that link, we will post it to this group. We're so excited to read it. Sounds awesome. Now let's get started with our Q&A section. If you have any additional questions, feel free to post them in the comment section. And if you're watching this after the session has concluded, just feel free to post them and I'll make sure Dr. Brandeis sees them. He's fantastic about getting us answers. So the first question, Dr. Brandeis, can you address the pain associated during treatment secondary to the ballistic nature of the radial versus shockwave?
The pain is a great question. I have 2 radial devices and I very infrequently get complaints of pain from either of my ballistic radial devices. Honestly, I don't know how to answer that question because I don't have enough experience with the focused devices. Maybe someone out there has a focused and a radial device and can comment on that. I just haven't found discomfort to be really an issue, except for Peyronie's patients. Some Peyronie's patients with a 6mm tip turning up the juice a little bit will have discomfort, and I'll have to give them a nerve block or something like that. Okay, thank you. And I believe you already said this, but can you repeat your standard settings? On my Zimmer, I use 90 to 100 millijoules, a rate of 15 and 10,000 shocks. And on the eVive, I think it's 2.6 and a rate of 15 and about 10,000 shocks. Great, thanks. Next question is, would there be a case where different patients react differently to one type of wave versus another? That certainly could be the case. As far as I know, of the physics of it, the waveforms are pretty similar. I mean, the difference between 10 microseconds and 10 nanoseconds, I think would be imperceptible to a human being and to physiology. I could be wrong, but it's such a brief period of time that I think that it would be really imperceptible.
Okay. Yeah, that's what the research shows so far. So our next.
I mean, it'd be interesting to see if there's any biological system in humans that can differentiate between something that occurs in a millionth of a second versus something that occurs in a billionth of a second.
Right.
And I nothing comes to me off the top of my head.
Okay, no problem. So our next question is from a provider who is asking, are you giving treatments once or twice weekly?
A lot of it depends on the patient's schedule. There's really never been a significant difference between those two protocols. There's, I think, one paper out of the group from Greece that compared a once a week and twice a week protocol and showed that a once a week protocol was slightly better. But I don't, it's more about patient convenience than I wouldn't do 3 times a week. Okay. And I wouldn't do once every other week because I think that things have to build on each other. But once or twice a week, I think it doesn't really make a difference.
Cool. And would there be a case where you would want to use both focused and radial? I think that's the whole point, is that there wouldn't be, right?
I don't think anyone's ever looked into that, so it'd just be purely speculation, but I don't think so.
Okay. And which benefits truly does the 180K machine claim? We should probably look that up, right?
Yeah, I think you would have to ask those folks. When I talked to them, they were making a big point that so the Alma Duo is the ED100 or the ED1000, which really is the grandfather of shockwave devices. So most of the early studies have been done on that particular device. And so what they can claim really is probably the most data of any machine. And that's important. But at the end of the day, if the results from that machine aren't any different than the results from any other machine, then the question is, do you want to pay that much more? Like, for example, do you go to Costco, Taylor?
Yeah, sometimes.
Okay, good. So when you go to Costco and there's a choice between Kleenex brand tissues, right, which are $4 a box, or Kirkland brand tissues, which are $1 a box, which one do you buy?
Probably the $1 box.
Yeah, I go Kirkland. I mean, I don't need to baby my nose, and I don't know that there's any studies that have ever been shown that that Kleenex tissues work better for cleaning up mucus than Kirkland tissues. In fact, from the manufacturing guys that I know in my practice, most of those guys say that these things are made in the same factory by the same people. They just put them in a different box. And so, I think it's great that they branded the ED100 or the ED1000. But if they want to charge triple the price, then they have to prove that they're getting triple the results. And thus far, to my knowledge, they haven't shown that. So I'll go with Kirkland until Kleenex can tell me that they do better.
Yes, agreed. And that's a really relatable comparison. So I appreciate that, especially being non-medical. So we have 2 more questions that I see. If you have any other questions, this is your last call for questions. Our next question is, do you start out with 10K shocks or do you build up to that?
We start out with 10,000 shocks.
Okay.
Yeah.
And then if combining P-shot and GAINSWave, what do you think is the best schedule?
I do P-shots at the end of treatment. I tell patients that GAINSWave is like planting a seed. You're stimulating stem cells, and that PRP is like putting fertilizer on. So you don't put fertilizer on a seed. you put fertilizer on a little plant.
Another great comparison. Thank you. And then I believe this is our last question. If we have any other questions, please do post them after the session concludes. Is there any information that shows taking a break halfway through a protocol has any increased efficacy? I know one of the largest providers in the country does 12-week protocol, 6 weeks, 1 time a week, followed by a break and then a resumption of the protocol. What are your thoughts?
Yeah, one of the early papers used that protocol of 6 treatments over 3 weeks, 3-week break, and then 6 treatment over 3 weeks. And I don't know what the rationale behind that was. Maybe somebody went on vacation or who knows. It's like we do so many things in medicine that are just kind of a legacy of the first paper, the first study ever done. Like, for example, the reason we all think that spinach has 10 times the iron that everything else does is because of a typo in the original paper, comparing spinach and all other vegetables. And so, I don't know what the benefit would be of taking a break. I know that there's one of the papers from the group in Greece showed 6 treatments followed by 6 months, followed by 6 treatments, and 12 treatments followed by 6 months, followed by 6 treatments, and showed that the group that did the best was 12 treatments, 6-month break, 6 treatments, followed by 6 treatments, 6 months break, 6 treatments. And so there clearly is a benefit from a maintenance protocol or reactivating the stem cells at some point. But what the exact protocol on that is, nobody knows. I think it has to be individualized. So for example, my patients who are a little bit more fragile, a little older, diabetics, so on and so forth, I will bring them in maybe in 3 months. And my younger guys, guys in their 50s who just want to get off Viagra, maybe they'll come in once a year to get a boost. And so I don't know if that fully answers the question, which, I don't think there really is any good answer for, but I don't think that there's any benefit of taking a short break in the middle, but I think there is benefit of 6 months down the line doing another treatment that will give you an extra 2 or 3 points on the shim score.
Right. Okay. Yeah, that makes sense. I do think that's all the questions we have for you today. As always, we truly appreciate your time in putting this together, breaking it down so clearly, and we are so excited to hear more information about your upcoming book. So thank you, Dr. Brandeis. And please, as I mentioned a few times, post your questions in here if you are watching this after the live session has concluded. We are so happy that you joined us today. And please email me, taylor@vitalityconnect.com, if you have any questions. Dr.
Yeah, no, I really appreciate it, Taylor. And to everyone that's out there, another reason that I wrote the book was because I learned a little bit through Mark White and through GAINSWave about the influencer community and the health influencer community. And there are a lot of people out there that don't have the medical credentials that people like you and I have. They haven't gone to medical school. They haven't gone through residency. They haven't been treating, hundreds of patients a month, but they have time to get out there on podcasts and the radio and TV and all that stuff, talking about healthcare as if they're doctors, as if they really know. Because the thing is, like, as physicians, you and I both know that there's an intuition that comes with actual treating patients, not just reading in the books, about pathways and facts and figures that you can quote, or comes with interviewing doctors, but comes with actually like being with patients, with operating on patients, with being in the trenches with patients. And so really what the light bulb that went off for me is that we need to be the influencers for our patients. And that's what this book is all about. Is I gathered 60 of the top private practice doctors that I could find in all of the different specialties. And so instead of somebody making up some ridiculous or not ridiculous idea about how to improve vision, I had Ahad Mahuchi, who's one of the top ophthalmologists in Florida, in Tampa, write a chapter on ophthalmology. And I had Joel Kahn, who's a fantastic cardiologist, write the chapter on cardiology. And I had my friend Ethan Bash, who's the head of oncology for the University of North Carolina and trained at Sloan Kettering, write the chapter on how to avoid cancer, right? We need to be the influencers for our patients. And we need to be the filter for all of the ridiculous and non-ridiculous assertions out there about health products, healthcare, so on and so forth. We've been the ones that trained. We're the ones in the trenches. We're the ones that understand what works and what doesn't work. And so that's what this is all about. And this, I'm giving you a tool that you can hand to your patients or sell to your patients, and which is filled with really first-rate verified information that you can be rest assured has been vetted by me and by top experts in all their fields. And so, when it comes out, I'm going to be reaching out to the GAINSWave community, and I hope that you really welcome this resource. So thanks a lot.
I will personally be grabbing a copy, so we're so excited. One last question. One of our providers asked if he can get a copy of your slides. Is that something you can provide?
Yeah, I think so.
Okay, very cool. Well, thank you, Dr. Brandeis. Have a great day, everyone.
All right. Thanks a lot.